Kaushik? Madhurima, Kaushik, that's the third presentation.
Yes, sir.
Yeah, can you please share your presentation?
Okay, sir.
Madhurima Kaushik and Dr. Tufaila Shafi are from Srinagar. So, Madhurima.
So can you see my screen?
Yes.
Okay, sir. Good morning, everyone. I'm Dr. Madhurima Kaushik from Department of Ophthalmology, Government Medical College, Srinagar, and I'll be presenting a case with a mistaken identity. The moderator for this presentation is Dr. Tufaila Shafi. Our case was that of a 27-year-old female who presented with gradual and painless diminution of vision in both eyes for 5 months. There was no history of distortion of objects. There was no significant past history. There was no history of ocular trauma, surgery, or systemic diseases. There was no history of steroid use in any form, and there was no significant family history. This patient had been treated as a case of central serous chororetinopathy at an eye care center, but there was no improvement in vision, and then she came to us. In the examination of the right eye, the uncorrected visual acuity was 6/24, which improved to 6/12 with a minus 0.25 diopter sphere lens. And in the left eye, it was 6/18, which improved to 6/12 with a minus 0.25 diopter sphere lens. The anterior segments were normal. In the fundus examination of the right eye, the disc and the vessels were normal. The macula appeared elevated, the foveal reflex was absent, and there was a round, well-delineated, shallow, serous macular detachment. Inferiorly, fibrous macular scars were present. A similar picture was seen in the left eye, and there were some scattered subretinal deposits which were visible. The first picture is a red-free photograph, and the lower panel shows pictures from the FFA in which we can see a diffuse mild hyperfluorescence, which was seen in the macular region, and the most significant finding was that of staining of the macular scars. Similarly, in the left eye, we can see a diffuse mild hyperfluorescence is present, which is not increasing in size in the late phases. There is staining of the macular scars, but there is no other extramacular lesion or any focal leak or any gravitational tracts that can be appreciated. So we did an OCT and found bilateral neurosensory detachments with scattered subretinal deposits, which were more in the right eye than the left eye. And as this case had been looked at as a case of CSR, we also measured the subfoveal choroidal thickness, which was 272 microns in the right eye and 300 microns in the left eye, which fell within normal limits. So at this point, since we could not find any clear leak, laser was not an option. What we were left with in our hands was to either do an ICG and find some choroidal leak, which then we could have done in PDT. But because these modalities are not available with us and the patient had persistent subretinal fluid and low vision, we decided to go with a trial of 1 dose of intravitreal bevacizumab in each eye. But after 6 weeks, she still had no response to those injections. So at this point, now we're faced with a situation where we feel there is a diagnostic dilemma. Are we really dealing with chronic CSR, or is there something else that is evading us? The points that are in favor of a diagnosis of CSR are the bilateral neurosensory detachments with subretinal precipitates. Points against it include a non-specific FFA and with no clear leak. There are no gravitational tracts, and why are there macular scars? Moreover, CSR in females is usually diagnosed during middle age. So could this be an atypical macular dystrophy with bilateral central macular scars? We searched the literature and found case reports where patients have been misdiagnosed with chronic central serous chororetinopathy, but they actually had atypical vitelliform macular dystrophy. We screened our patient, the family of the patient, but that was clear. So at this point, we have advised the patient to obtain an electrooculogram and genetic testing, but these are not available in Kashmir. So she will have to travel out of the state for these and spend significantly. So are we on the right track? The case is open for discussion now. I request Dr. Tufaila to take over from here.